Stephanie Chisolm, who we've had the pleasure of working with over the last few years. Stephanie brings many years of experience in urology and education for patients and healthcare providers to the Bladder Cancer Advocacy Network. As the Director of Education and Research at BCAN, she leads efforts to raise bladder cancer awareness among the general public, inform and empower bladder cancer patients and caregivers, and advance research to improve the lives of those touched by bladder cancer. Thank you again, Stephanie, for joining us today.
Oh, it's my pleasure. Thank you, Judy, and welcome, everybody. We're very excited to have you on this webinar. You're in for a lot of really great information. I'd like to introduce our speaker, Dr. Jean Hoffman-Censits. She's the director of the Multidisciplinary Genitourinary Oncology Center at the Sidney Kimmel Cancer Center, and she's associate professor of medical oncology at Thomas Jefferson University in Philadelphia. I've known Jeannie for a number of years, and she's going to give you a great presentation. Her professional interests include urothelial carcinomas of the bladder and upper tract, as well as advanced prostate and renal carcinoma. Dr. Hoffman-Censits currently serves on the Genitourinary Core Committee of the Eastern Cooperative Oncology Group and on the Clinical Trials and Standardization of Care Committees of the Bladder Cancer Advocacy Network. So we're really delighted that she's able to join us. Thanks, Jeannie, for coming.
Well, thanks, Stephanie, and thanks for the Inspired community for having me. It's an honor to be here and to talk to everybody about updates in muscle-invasive and advanced bladder cancer today. Oh, there we go. Just having a little bit of delay with the slides. There we go. So, as physicians who treat bladder cancer, we think about the pillars of cancer therapy, all the different tools that we have in our toolkit to treat patients, and to put the talk, into context. For bladder cancer, we use a lot of these things. We use, surgeries in the mainstays of therapy, of course, for diagnosis and for treatment. Radiation therapy is is an important tool that we use. Chemotherapy, first discovered and starting to be used in the 1940s, a very powerful tool. Targeted therapy is, I think, becoming more and more relevant in bladder cancer, although no FDA-approved drugs necessarily as of yet. Well, now all the splash and what everyone is seeing kind of in the news and with the lots of FDA approvals and Jimmy Carter is immunotherapy. Now, we've known about immunotherapy in bladder cancer for a long period of time, since the 1970s. Our urology colleagues have been using BCG to treat bladder cancer. So there's been a long history of the immune system being stimulated and educated to treat cancers, but taking it from a local treatment perspective with BCG and then expanding that into systemic therapy was never successful until the first systemic immunotherapy was FDA approved in 2011 for melanoma. That was ipilimumab, and since then the field has really exploded. So bladder cancer is a problem that a lot of people don't know about or hear about until they themselves or somebody that they love is diagnosed with bladder cancer. But when you look at this, compared to prostate cancer, lung cancer, and other cancers like breast cancer that get a lot of press, bladder cancer is a very prevalent disease, and compared to how many Americans have bladder cancer, the funding is really pretty poor. So if you look at the right side of the screen in terms of we as clinicians are seeing patients, most patients present with non-invasive bladder cancers, non-muscle invasive tumors, and the majority of those patients are taken care of by our colleagues in urology practices. That is really the majority of the cancers, but that's not going to be the main focus of this talk today. The focus of the talk today is me talking about locally invasive cancers, tumors that are invading into the bladder wall, taking up root, or invading into local lymph nodes, or patients that have either recurrent or metastatic disease, meaning that it's moved from the bladder into other sites of the body. So, like I said, most patients, about 75%, will have superficial or non-muscle invasive disease. Now, non-muscle invasive disease and bladder cancer in general tends to be a disease that, at least the localized disease, can be one that can be managed and managed successfully, but one that recurs over and over again. And because of that, it is a very long-term relationship that patients have with their urologist. And it's also a very expensive disease to treat because the gold standard is to do in-office or operative cystoscopies. And as you can imagine, doing that over and over again really, can carry with it a lot of, potential risk and cost. So there's so many different areas that we as folks who think about all the different problems we have in bladder cancer every day, that's certainly an area that we know needs additional work to make the surveillance for bladder cancer less onerous for patients. But 20% will present with locally advanced disease, and then 5% with metastatic disease. And then, of course, from the stage standpoint, the lower the stage, the better overall kind of rate of overall survival is for bladder cancer. But we certainly know that these numbers are not absolute. But in general, from a medical oncology perspective, where we get involved and start talking about systemic treatment like chemotherapy is when tumors are invading into the muscle layer of the bladder or beyond, into the perivesicular fat or into the lymph nodes. So there were some questions about chemotherapy and giving chemotherapy in preparation for cystectomy. If we kind of go back for a second, tumors that are invading into this muscle layer here or beyond, this is really our line in the sand where we start talking to patients about taking out the bladder. And the reason for that is because the risk of the tumor locally advancing into lymph nodes or metastasizing into other parts of the body becomes much more substantial versus a tumor that can potentially be scraped off and treated locally here. So, some patients get very used to being treated with BCG, and if their physician says that their tumor has changed character and instead of being a non-invasive tumor becomes an invasive tumor, how does the chemotherapy that we give in the perioperative period or before a cystectomy, how does that differ from BCG? Main difference is that the BCG goes into the bladder, whereas the chemotherapy that we give goes into the IV. BCG is, of course, an immunotherapy, and as of right now, the standard of care remains to give chemotherapy prior to a cystectomy. There are a few different chemotherapy regimens that are available that we use prior to a cystectomy. Both of them contain a drug called Cisplatin that is the most active agent in bladder cancer, and we do not believe that other regimens that do not contain Cisplatin are the best ones to give before surgery. How does chemotherapy work? So chemotherapy is a very non-specific kind of drug, and the reason that chemotherapy gets a bad name and that patients get toxicity is that chemotherapy it doesn't know whether or not it's attacking a normal tissue or a cancer tissue. It just impairs rapidly growing cells from making themselves over again, and so our gastrointestinal tract and hair follicles also will suffer the consequences of that. Those toxicities do tend to be transient toxicities, but for some patients, those toxicities can last a long period of time. I think one of the great questions that came in is, how can we mitigate some of those toxicities? How can we decrease those toxicities? And I think part of it, I wish we had a better answer than patient selection, but that's one of the things that we think about is, kind of as a medical oncologist, weighing the potential benefits of chemotherapy with the potential risks of treatment. And we always ask those questions about hearing and about numbness and tingling in the fingers and toes called peripheral neuropathy, and thinking about things like cardiac status so that we can better select patients that may be the best candidates for chemotherapy and discuss, potentially holding or deferring chemotherapy for those that we think that the risk to benefit ratio may be too high. But as of right now, as far as I know, and Stephanie, unless you have any other thoughts, we don't have any specific clinical trials or medications that we use as a standard of care to decrease the risk of toxicity from chemotherapy. At what point is chemotherapy started? This has been a long discussion in our field for a long period of time. And the standard of care does remain that chemotherapy prior to surgery is preferred. There are different kind of practice patterns sometimes across the country, but the chemotherapy before surgery is preferred for a couple of different reasons. One is that in general, patients are fitter and healthier before a radical cystectomy than they are afterwards. It's a tough procedure to get through. One of the, and many of you know that much better and more kind of acutely and directly than me giving this talk, but not everybody that gets a radical cystectomy on the other end is ready to get chemotherapy in the weeks or months following surgery. The other thing about getting chemotherapy before surgery is that if a tumor completely shrinks down and melts away, well, that gives us some indication of the sensitivity of the tumor to chemotherapy. That gives us some prognostic information that I think is important that we can share. Is the chemotherapy preventative? The goal is to decrease the risk of micrometastatic disease or tumors that can lay dormant and then grow back. The number of cycles of chemotherapy, we actually just had a discussion about this with the FDA. There are multiple different trials out there that give somewhere between 2 and 4 or 6 cycles of chemotherapy, but in general, most of us are giving 3 to 4 cycles of chemotherapy. We talked about some of the toxicities, which can include decrease in blood counts that can put patients at risk for serious or life-threatening infection. You can get tinnitus or ringing in the ears or decrease in hearing, nausea, vomiting, diarrhea. Although with modern antiemetics or anti-nausea medications, we hope that that won't happen, as well as numbness and tingling in the fingers and toes. Who's chemotherapy not suited for? So one of the things that we really pay attention to a lot in genitourinary oncology is kidney function or renal function. So cisplatin is both metabolized or broken down by, as well as toxic, potentially toxic to kidneys. So we want to make sure that someone has has adequate kidney function prior to starting treatment, and that's a definite where if someone's kidney function is really poor, then the risk of chemotherapy is just too high, and we cannot offer it. And can it cure bladder cancer? I think that is a question that we don't quite know the answer to yet. Standard of care as of now includes chemotherapy followed by what we call consolidation or some kind of a treatment, either surgery or maybe even moving on to radiation. But chemotherapy on its own is not felt to be standard of care, and I think that was a question that came in as well. So in terms of the regimens that we have, cisplatin is this driver drug that we talked about. It interferes with DNA repair mechanisms that causes DNA damage and then cancer cell death. Like I said, it's the most active primary treatment in locally advanced and metastatic bladder cancer, and it's supported by what we call level 1 evidence, which means that clinical trials have shown that that drug, or a combination of cisplatin with other drugs, leads to what we call overall survival, meaning comparing one group to another, that the addition of cisplatin helps patients to live longer despite their cancer diagnosis. The safe delivery of cisplatin, when I see a patient in the office and I think about whether or not I'm going to offer that cisplatin-based chemotherapy, we do think about these things, which I in part discussed before. One of them is something called performance status or functional status. If someone from their cancer or from other, what we call medical comorbidities, other diseases, is so weak or so frail that it's hard for them to maybe get out of bed, hard for them to dress themselves, hard for them to do any kind of activities of daily living, then potentially the risk of chemotherapy might be too high. So we really have to take that into consideration. Hearing loss, I think, is a really challenging potential toxicity to discuss, because there's some patients that will say, Doc, if I want you to do everything possible, and I understand that I may have, long-term ringing in my ears or progression of my underlying, hearing problem. Other patients say, there's no way I'm going to, accept that risk. So that's always a long discussion. peripheral neuropathy or numbness and tingling in the fingers and toes. A lot of people have that, either what's called idiopathic, meaning they just have it, we're not quite clear of the underlying mechanism, or they have maybe insulin-dependent or non-insulin-dependent diabetes for a few years and have developed a little bit of neuropathy. So each time someone comes in for chemotherapy, we'll talk to them about that, and sometimes either cut doses or hold doses because of that. We give a lot of intravenous hydration to support and protect the kidneys during chemotherapy. And because of that, we have to make sure that cardiac status and ejection fraction would handle that, as well as going through with a radical cystectomy, which is a big surgery. And then, of course, the kidney function, which we discussed before. This is just a funny slide that I put together. Anybody who has dogs has seen this, I think, seen before in the bathtub. But in terms of when we give the chemotherapy, like I had mentioned, the preoperative chemotherapy, when we can, is preferred. And when you look in the literature and when you talk about what is standard of care, that's what we as most academic clinicians will practice. If someone went and had a cystectomy and maybe for BCG refractory disease, where there was a decision made about cystectomy and it was found at the time of cystectomy that maybe the tumor was more locally advanced than was originally noted, maybe there were positive lymph nodes or the tumor was invading, past the fat. Well, that would certainly be, I think, a discussion point where we would talk about post-operative chemotherapy. But I think if you polled most oncologists across the country, we would prefer the pre-op versus a post-op chemotherapy for a lot of different reasons. So how do we know all this? Where does all this information come from? So, what I tell patients and what is true and what we do every day is participate and run clinical trials. And so nearly everything that we know about how we treat bladder cancer is based on these clinical trials that were done in the past and clinical trials that are ongoing. Taking a hypothesis, taking a question and really testing it in what we call prospectively in a population of patients, saying, we believe that chemotherapy and surgery is better than chemotherapy alone, but we actually have to prove that, we have to show that. And that's what this study shows. This is one of about 4 studies that have shown that giving cisplatin-based chemotherapy prior to surgery improves overall survival, and that's where that level 1 evidence comes from. So when you look at the number of patients surviving in the months after they were randomized, which means neither the doctor nor the patient could select which group they went into, because this is before that we proved chemotherapy before surgery improved overall survival. And the patients that had the chemotherapy plus the surgery did better than the surgery alone. And whenever we as physicians see that, and whenever the FDA sees that, and there's a statistical significant difference between these 2 arms when it comes to living longer from a cancer diagnosis, that's when standard of care changes. The other thing is just looking at the patients that had what we call pathologic complete response. So at the time of cystectomy, those patients that had no evidence of any tumor within the bladder, meaning that the chemotherapy melted away the tumor, versus those that had any residual tumor, those that had no tumor did better, they lived longer than those that had residual disease. And that makes sense. If someone has a tumor that is refractory to the best chemotherapy that we can give, well, it makes sense that maybe that's a more aggressive tumor. That tumor just behaves differently, and therefore potentially their survival is going to be different. I think someone asked a question earlier about doing a transurethral resection alone. That was one of the questions that came in. And is that enough? And the answer is probably not, and that's certainly not supported by standard of care. But we do recognize that all the treatments that we do, it's a lot for patients to go through. And we recognize that, that's what we call an unmet need. That's something that we think that we would like to improve upon. So there are definitely clinical trials ongoing or being built to address, are there other things that can potentially be done other than chemotherapy and radical cystectomy that everybody would get. But as of right now, to just have a transurethral resection alone for muscle-invasive disease would not be considered standard. What we did see that with this trial and others is that if someone just had a transurethral resection and then went on to cystectomy, maybe about 15% of those patients, and this was with a very aggressive transurethral resection, would have complete disappearance of their tumor. But that number, was more than doubled in the patients that got chemotherapy. And again, it's this group of patients that tends to do the best. And so that's the addition of what the chemotherapy gives. And these are those statistically significant benefit in terms of overall survival, months of survival, 77 versus 46 months altogether. And when you break it down by age or based on stage, it didn't matter. The chemotherapy was still beneficial. This is just a summary of what we know about some of the large preoperative chemotherapy studies prior to cystectomy. The prior slide was looking at some of the GEM-CIS studies, and then this is a modern regimen with a regimen called Dostans MVAC. This is a pretty quick and efficient regimen where patients can get chemotherapy all in one day, about every 2 weeks. So I want to talk a little bit more about giving chemotherapy in muscle-invasive and advanced disease. I'm going to talk to you about the schedules of the different chemotherapies that we give, as well as the side effect management. So the first one is if we were to prescribe the Dostans MVAC regimen. MVAC stands for methotrexate, vinblastine, adriamycin, and cisplatin. That's 4 drugs altogether on one day. Now that one's on a 14-day cycle. So if someone were to start their first cycle on a Monday, they would get all their treatment here. This is given upfront with standard what we call prophylactic growth factor support, meaning that they get a Neulasta injection. Some centers give it the same day, and patients have an auto-injector where the drug is delivered from that auto-injector 24 to 48 hours later. Others may have to come back the following day or later in the week to get that injection. And then the rest of the time is off until they come back on cycle 2, day 1. We will typically get labs either on cycle 2, day 1, first thing in the morning, or maybe have patients get labs the Friday or the Saturday before in anticipation of that chemotherapy. And like I said, we will either plan for 3 or 4 cycles of chemotherapy depending on the center and how patients are tolerating treatment. The alternative regimen is cisplatin and gemcitabine. So, how do we make the decision for one versus the other? These two have never been put what we call head-to-head. So there's no level 1 evidence to give one versus the other. One is not felt to be better than the other, but they've never been essentially tested that way. What we do know is that the Dostans MVAC is a pretty quick and efficient regimen, as you can see by the schedule. But the other part of this regimen is a drug called adriamycin, and this is what this is a drug that is potentially what we call cardiotoxic. So we want to make sure that someone's pump function of the heart is good. If it's not, then we would choose this regimen instead, and that's the cisplatin or the gemcitabine. Now, this is the first time I'm introducing a drug called carboplatin, and the reason I'm doing that is because both of these regimens, either the MVAC or the cisgem, are the same regimens that we use preoperatively or for patients that don't get preoperative chemo postoperatively, and what we call in the first line if someone has metastatic disease. We prefer to use the cisplatin when we can, but if we can't and someone has advanced disease, then we use a drug called carboplatin. Carboplatin is a little easier on the kidneys. It's a little harder on the platelet and the blood counts. But when you compare the carboplatin to the cisplatin head-to-head, the cisplatin is a better drug, and so that's why we use that over the carboplatin. If we were to use this regimen, patients will come in for cisplatin or carboplatin and gemcitabine on day 1, and then on rest of the week off, and then on day 8, they would just get the gemcitabine alone, and then start back up again. There are regimens where patients will get gemcitabine again on day 15, but they can be what we call myelosuppressive, which means that the blood counts can get fairly low on these regimens. And to save patients from coming in and then being sent home because the blood counts are inadequate, a lot of us have gone to a 21-day regimen, meaning starting here and then cycle 2 is here, as opposed to having patients come back and maybe having a 50-50 shot of getting full-dose chemotherapy. So the side effects of platinum-based chemotherapy, I tell patients that, we go through a laundry list of the side effects of treatment, and I understand that that list of side effects can be very, very scary. The thing that we absolutely expect is fatigue. So getting chemotherapy and giving chemotherapy, the expectations for the side effects, it's almost like, running around a racetrack or driving a car, around a motor speedway, that at some point during the cycle, these different side effects will happen. And then as you kind of get back to your starting line, those side effects tend to wane and get kind of ready for the next cycle of chemotherapy again. Patients don't always get back to their baseline level of functioning prior to starting the chemotherapy before the next cycle, but are well enough to generally get a next cycle of chemotherapy. If they are not well enough to get a next cycle, or if the counts are inadequate or there's something else going on, then we will hold until someone's body is well enough to get treatment, because we always have to balance trying to attack the cancer, but the person, the patient who's getting the chemotherapy, has to put up with all the side effects. And if they can't do that, then we're not going to get very effective, cancer treatment. So the thing that we absolutely expect is fatigue. I tell patients and families, we expect fatigue where the point is you get up, you make yourself some breakfast, read the newspaper, put the cereal bowl, into the sink, and then decide maybe I'll go take a nap or sit down. But no one should ever be so tired they can't stand up or lift their head off the pillow. That's infection or dehydration until proven otherwise. In general, cisplatin-based regimens will cause what we call alopecia or hair loss, so that is to be expected, and nausea. With modern antiemetics, with modern treatments that we give for this regimen, my goal is that patients are not throwing up. It's such a terrible experience to throw up, and if someone is nauseous or throwing up, then it's likely that they'll also become dehydrated, and then that puts you at risk for more problems with the kidneys, and we definitely don't want that. So I like to make sure that people know that that's really not expected. Sometimes, someone may have had a family member with a different malignancy, and maybe that was 10 or 20 years ago, where the toxicities were much worse. And even with MVAC chemotherapy that we give, that New England Journal paper that I showed you, the patients, the toxicities that they had from, in that regimen at that time when the drugs were tested and approved were so different than what we see nowadays. A lot of patients were admitted to the hospital because they needed fluids every day, and that's incredibly rare nowadays, that patients need that much support with the medications that we give to counteract nausea and vomiting. So even though our regimens haven't changed in a long time, how we give them and how we support people through them have. So that's definitely an improvement. You can see ringing in the ears. You can see sores inside the mouth. Often that's a sign that the white blood cell count is low, so that's just a time to be kind of extra careful. Numbness and tingling we talked about. The chemotherapies can cause not only what we call peripheral neuropathy with the numbness and tingling, but also kind of a visceral neuropathy, and that can lead to this constipation, as can some of our supportive care medications, like Zofran can make you constipated. And we can see some transient liver function changes that tend to improve throughout the cycle. There was a question that came in. Someone had talked about a family member that had a DVT. And, bladder cancer, and especially metastatic bladder cancer, patients that are very, very high risk of having blood clots. We don't necessarily prophylax or, treat people who don't have blood clots to prevent them, but we keep our ears perked up for any signs of blood clots, like, asymmetric swelling in the lower extremities, asymmetric edema, or, erythema or redness, pain in one leg or another, and of course any chest pain or shortness of breath definitely gets our attention. But having metastatic bladder cancer or localized bladder cancer, locally advanced bladder cancer, and then getting this chemotherapy at the same time can definitely put you at a higher risk. So something to keep in mind. And we've already talked about the kidney function. In terms of the blood counts, we do our best to remind patients to get routine vaccines like flu shots and pneumovax if age appropriate, to potentially decrease the risk of infection. But if folks are going to get infections during chemotherapy, try as we will for good hand washing techniques and things like that. If someone has a bacterial infection during chemotherapy, it's often from what we call enteric bacteria, so bugs that are inside your body, and part of that is because having an intact immune system with a normal white blood cell count kind of keeps your gastrointestinal tract and the genitourinary tract intact, and then losing that, during the course of chemotherapy can increase what we call the transition of bacteria from those internal organs in those internal structures, into the central system, and so that's where a lot of infections can come from. For fatigue, we recommend just staying really well hydrated and nutrition as best as you can. Sometimes people don't want to eat, but Boost and Ensure are great. For the hair loss, I think preparation and just knowing that it's coming is definitely important. And I do tell people to expect complete hair loss. Sometimes it doesn't happen, but if you expect it ahead of time, at least it does not come as a shock. For nausea and vomiting, we make sure that we send people home with all the medications that you need in the cabinet, as well as written information about how to use them and a phone number in case you need them. Mouth sores, medicated mouthwash, as well as recognition that if you aren't able to swallow, that we really do need to support you with intravenous fluids or hospitalization. Numbness and tingling, just to be sure that you let your doctors know if you have that, so that we can address it in clinic and make potential changes to the chemotherapy toxicity. Same with the vascular side effects. With the kidney function, sometimes that can come from a bunch of different things. So, the kidneys are connected to the bladder by these straws called ureters, and depending on the location of the bladder cancer, those ureters can be obstructed or blocked by the tumor. So for some folks, they are able by their urologist or for an interventional radiologist to get a stent to bypass that obstruction, but some can't. And so we have to be mindful of that a kidney can become functionally blocked, or the plumbing can become blocked either at the time of the diagnosis or sometime afterwards. So any abrupt change in kidney function, we sometimes will send a patient for, a kidney ultrasound to be sure that all those pipes look like they're open and that the kidney is not backing up. If the kidney does black up because it's blocked, you get something called hydronephrosis, and some of you may have seen that word on a scan, and essentially it just means that there's fluid in that tube and it's backing up the kidney. If that doesn't get decompressed over time, you can have a permanent change in kidney function. And then again, the blood counts put you at risk of infection awareness and growth factor support. So another question came in about mitigating some of the side effects of chemotherapy, and I think I'm not sure if we're doing our best to come up with better treatments. We're definitely doing that, but at the same time, kind of addressing, well, we know that there's some patients that have a complete response to chemotherapy, and then we know that there's some patients that don't respond to chemotherapy, and in fact even have their tumor progresses on chemotherapy. And if we know what the differences are between those two populations of not people necessarily, but tumors, if we can differentiate what the differences are, then that would be important. And then maybe we can use that information when we are treating general populations. And so that's what this is. So this is from our group and others that showed that if tumors had what we call DNA repair defects, that they were more likely to respond to chemotherapy than those that didn't. And so this information has been replicated by other groups and then is the basis of a clinical trial that's coming up that may allow patients that have a very, very good response to chemotherapy in the setting of that clinical trial, not as a part of standard of care, to potentially be watched and not go on to get a cystectomy. But that, again, is in a clinical trial setting. So we are working on these things. We are asking these questions of ourselves and trying to come up with alternatives, but we're not there yet. But we're starting that process. So cisplatin-based perioperative chemotherapy summary. So cisplatin-based chemotherapy is recommended for patients that have what we call pathologic T2 or muscle-invasive cancers. It improves overall survival and decreases the risk of recurrence, and that would also go along for node-positive disease. Careful patient selection can improve that ratio between the risk of treatment as well as the benefit of treatment. The side effects are typically manageable. Some of them, unfortunately, can be long-lasting. And perioperative chemotherapy is generally endorsed for patients with high-risk tumors who did not receive pre-op chemo. So post-op chemotherapy, we'll definitely have a discussion about if someone did not get it. And the optimal number of cycles isn't clear. So in terms of whether or not someone is a candidate for cystectomy or radiation therapy, one of the first questions that we ask ourselves, of course, is is this someone that can go through surgery? Do they have, severe heart disease where the anesthesiologist would be concerned about their ability to get through surgery or not? And of course, if someone, tells our team that there's, a patient is too frail to go to surgery, but they, would need it or have an advanced tumor, then I think we really have to think about radiation. Are they a bladder preservation candidate? And what does that mean? And we'll discuss that in a minute. If they're not, then we would recommend cystectomy. But if they are, then it's a discussion between either cystectomy or radiation therapy. And what does this mean? So to keep a bladder, I think one of the things to think about is that bladder a functional bladder? There's some folks that have a history of bladder cancer, dating back maybe a decade or so, and have, pain with urination that's been going on, for years, or frequency where they're getting up, 4 or 5 times a night, or can't sit through a movie, or can't go on a road trip, because of that frequency. So getting chemoradiotherapy to the bladder may not change those, physical limitations, and so that's something that needs to be taken into account. But if someone has that hydronephrosis or a blocked kidney, if they're unable to tolerate the chemotherapy that we give that boosts the radiation therapy, if they have something called carcinoma in situ, which is that kind of precursor lesion, if they have it in multiple different places in the bladder, then that bladder is at risk for developing other cancers later that can be challenging to treat. And then, of course, if someone has a tumor that's invading into the prostate, which is connected to the bladder, these are all reasons why we do not think that someone would be a good candidate for radiation, because we don't think that it would necessarily be the best chance of being a successful treatment. And then that patient would be counseled about, having a radical cystectomy instead. But of course, if they don't have any of those high-risk features and just have one lesion, a small lesion, no evidence of any of these high-risk features, then the radiation, I think, should be discussed. What we don't have is a randomized study comparing these patients without high-risk features of, half getting radiation and half getting surgery. We don't have that, and I think that's in part because certain centers have, I think, preferences for one or the other, and I think patients have preferences for one or the other. But it would be a very important question, I think, to think about. But I think at the end of the day, it's important to talk to patients about what the different options are and why we may or may not recommend the tumor. So in general, when we do talk about radiation and a multidisciplinary team, meaning more than one physician has to be in on this because we give radiation, we have to have an aggressive and follow-up transurethral resection, and then a medical oncologist. So there you've got 3 physicians on board, talking to the patient and the family. We want to be sure that we hit all these marks to ensure the best chances of a good outcome. So for patients with muscle-invasive disease, local control with a single modality of treatment, meaning just transurethral resection, is really low. So just transurethral resection alone can be expected to get about a 20% likelihood of local disease control, and that doesn't mean that that's durable, that would last for a long period of time. Radiation alone without chemotherapy, maybe a little bit better. And so that's why we talk about combining these 3 modalities: a really good transurethral resection, and then radiation, and synergizing that with chemotherapy to get the best outcomes if that is chosen. And again, careful patient selection. No evidence of any blockage, a very functional bladder. And then lastly, this transitional cell histology. So looking under the microscope, bladder cancer is not just one disease. Bladder cancer can be made up of different what we call histologies under the microscope. And those that have a very aggressive form called small cell, really depending on the investigator, might not be the best option. I'm going to move on to talk about, these are some radiation slides. I'm going to talk about metastatic disease and some other questions that we have about the immunotherapy treatments. And if needed, we will come back to these later. These are just more information about the regimens that we give. So progression beyond platinum. Prior to 2016, if someone had either carboplatin or cisplatin and had progression of disease, we had small trials that showed maybe that some chemotherapy, could give someone some benefit, but nothing that we felt that would be life extending. And so we were giving chemotherapy in what we call the palliative setting, and that changed in 2016. This was one of 5 drugs that is now FDA approved for patients with platinum refractory cancer. This is pembrolizumab. This is one of those large phase 3 studies, and this trial, as well as others, changed standard of care. So these are patients that had platinum-based chemotherapy and then tumors progressed afterwards. Half of them got pembrolizumab, which is an immunotherapy, and the other half got a chemotherapy drug, either docetaxel, paclitaxel, or a drug called vinflunine. The patients who had pembrolizumab, they lived longer and did better than the group of patients that had the standard chemotherapy in terms of their overall survival. The patients who were responding to treatment, meaning the tumors got smaller on the scans, who got the pembrolizumab treatment, these are called swimmer's plots. Each of these lines is an individual patient on treatment. They were actually on the treatment for much longer than even those patients that responded on chemotherapy, and it's likely because of the difference in toxicity. This is an easier drug to tolerate in general than chemotherapy is. And almost everybody who did respond to treatment responded at that first set of scans. Sometimes the responses are a little bit later in immunotherapy than they are in chemotherapy, but that just gives you a sense of, kind of comparing how each individual patient does on chemo. And then all these arrows mean that on this clinical trial, these patients are still receiving therapy. This is a summary slide of the 5 drugs that are FDA approved for bladder cancer following chemotherapy, and 2 of them, atezolizumab and pembrolizumab, are also FDA approved for patients that cannot get that platinum-based chemotherapy, that have changes in kidney function or severe hearing loss, or would be quite worried that they may develop deafness on treatment. So if you look at the landscape of how we treat bladder cancer in 2017, we do, as medical oncologists, kind of think of patients: are they eligible to get that platinum? Are they fit enough, healthy enough, or are they not eligible to get the platinum? And if they are, then they will get platinum in the first line. And if they have disease progression despite getting platinum, that's what we call an unmet need. That was our new unmet need a long time ago, and that's been answered by these what we call checkpoint inhibitors that you just saw the summary slide of. In general, the response rates are about 20%, depending on the population that we're looking at, with a durable survival in selected patients that are responding. In patients who cannot get cisplatin-based treatment, they will bypass this line in general and either get single-agent chemotherapy or either atezolizumab or pembrolizumab, with an impressive response rate as well as a clinical benefit, which means some people have stable disease over time. Their disease isn't growing or changing, and then they continue to get a drug, to get one of those checkpoint inhibitors. These are just some selected studies, so we're using a lot of treatment, immunotherapy treatments, to understand whether or not if someone got preoperative chemotherapy, had a cystectomy, but had maybe a positive lymph node or still had residual tumor that wasn't killed by chemotherapy. What we do for that population of patients is just watchful waiting. Get a prescription for a CAT scan every 3 months, and then we will treat if the tumor comes back. Well, since we have really effective post-platinum therapy, we're doing what we call adjuvant studies, so testing that standard of care, just scans alone versus scans plus an immunotherapy, and there's several ongoing clinical trials trying to answer that question. So in terms of future directions, so one is combining things together. We know that there's a lot of things in life that when you put them together, they're better than they are alone. And we know that some patients' tumors will respond to treatment in part because they're infiltrated. There's a lot of immune activity. There's a lot of inflammation within the tumor, but some are not. So for those, potentially if we combine different immunotherapies together, we may get a better outcome. And or if we combine immunotherapy with chemotherapy. And this is just an example of one of those clinical trials combining chemotherapy with immunotherapy prior to surgery, and these are a few in the advanced population. So if if a patient went through chemotherapy and went through immunotherapy and their tumor still progressed over time, where are we with that group of patients? And again, those patients have an unmet need. And this is where we start to think about another class of drugs called targeted therapy. Some of you may have had something like this. So there's a lot of companies that do what's called commercial next generation sequencing, where we take a piece of the tumor and ask the tumor to tell us something about it. Ask the tumor to say, what makes you tick? What's wrong with you that's making you grow? What do you feed on? And we can get a report that looks like this. This is a report that really shows a lot of abnormalities, a lot of mutations. This FGFR3 abnormality is pretty prevalent in bladder cancer, about 20%. And there are drugs that are in clinical trials trying to target this pathway in bladder cancer, trying to kind of shut off this switch to see what we can do. These are FDA-approved therapies in other tumor types. These all happen to be kidney cancer drugs. But depending, we can either talk to patients about clinical trials or talk to insurance companies about trying to get treatment, if appropriate. This is another, I think, pretty exciting part of our field, something called an antibody-drug conjugate. I like to think of this like a smart bomb. So this is an antibody which then can bind to a protein that's expressed on the outside of tumor cells, and this antibody carries with it kind of little pellets of chemotherapy. And instead of this chemotherapy kind of going everywhere, the chemotherapy instead gets targeted directly into the tumor, and then it gets sucked in and it kills tumor cells. So it's a pretty smart way of delivering chemotherapy. There's still toxicity associated with it, but there's a couple of different of these antibody-drug conjugates that are kind of in the pipeline and with some good effects that we're seeing post-treatment. I went pretty fast, but I wanted to provide everybody with the opportunity to ask, and we can talk about some of your questions. I want to thank the Inspire Network, and I want to thank Stephanie and the team at BCAN, who do amazing work to educate the public and to support patients and families with bladder cancer. And thank you, everyone, for your attention.
Oh, thank you so much, Dr. Hoffman-Censits. This is an excellent presentation, and I know that the slides will be sent out in a couple of days, so everybody will be able to go back through and ask their doctor specific questions. And I just want to remind you, we probably have about 10 more minutes for actual questions. So if you haven't submitted a question, you may go ahead and do that right now, and we'll try to get to as many questions as we can. We did have a few that were sent in advance of the webinar today, and so I'm going to ask those questions, and Dr. Hoffman-Censits, if you can kind of give a general answer, because we know that you can't answer specifically about individual patient information because you don't know all of the details. So one question that came in, my mother was currently diagnosed with stage 4 bladder cancer. She had metastases to her lymph nodes and bones, and now they say a spot on the bottom of her liver. Her doctor has her on a regimen of Avastin and Tecentriq every 3 weeks, and he recommended Tecentriq because she had her bladder out and she had a rough time handling chemo. We're just wondering what other options there might be for her, or should she try to go through chemo again?
I think this brings up the question that we all have about, now that we have these new treatments, the immunotherapy drugs, Stephanie, is how do we sequence them? So if someone falls into that category where they're ineligible, they're too sick or too frail to get a platinum drug, and we instead choose to use immunotherapy first, and they progress on immunotherapy or can't tolerate it, should that patient go back to get chemotherapy? We don't have a lot of what we call prospective data in the literature as of yet, but I think that these are all, really excellent questions. And I think what it comes down to is, like I showed with one of the first slides, we have tools in our toolbox to treat patients, and I don't think that there is a set regimen that you have to go through one or the other. And I think that chemotherapy remains a tool that every time we talk about changing a treatment, that we should discuss with patients and families, and then make a decision as to whether or not that's appropriate. But in general, if someone's tolerating a treatment and the treatment seems to be effective, again, cancer's job is to grow. So if someone's on immunotherapy and their cancer is stable, I think that's a success as long as the patient themselves is tolerating treatment. But it's a great question, and I think we don't know the answer to.
Okay, super. Well, thank you so much for that answer. Here's a question from today's program. I saw a neurologist after developing neuropathy from Cisplatin. He did some blood work and found an indicator of monoclonal neuropathy, the kappa light chain LGG. It's unclear if this is due to my treatment and what follow-up is needed. He indicated it could develop into a bone marrow problem called multiple myeloma. Can you explain that?
So, you know, like I had discussed, there's multiple different reasons why, medical reasons why patients can get a neuropathy or can present with, to us with a neuropathy. And, having multiple myeloma may in fact, potentially be one of them. A precursor disease to multiple myeloma is this monoclonal gammopathy of uncertain significance, and that may not even be readily evident based on labs, especially if you're meeting somebody that has a malignancy. So, having that MGUS may present with a little bit of anemia, a little bit of thrombocytopenia, but the same would be true of someone, presenting with a cancer, so it might not be kind of readily evident. But, I think that, seeing a neurologist or seeing a specialist about any of the side effects from chemotherapy is a reasonable thing to do. Whenever something happens that's impairing my treatment, I always ask, is this a reversible problem or a non-reversible problem? Is it a vitamin deficiency? Should we be checking B12 levels or, prescribing it and seeing? Is it something that can be mitigated with, medications that may, decrease the neuropathy? So anything that we can do to understand and potentially treat an underlying problem that would exacerbate a neuropathy or would separately give a patient neuropathy may then in the future allow us to give more therapy for the cancer. So I think that was a... I can't answer the specific question, but I think, having consultants on board is sometimes very helpful.
Okay. Yeah. Again, this is a great reminder for everyone that you don't have all of the details, and every bladder cancer patient is different, and their circumstances are different, and it's very hard to make a general statement like this when you don't have all of those details. So I do appreciate you giving what you can. And I know a couple of questions had to do with non-muscle invasive and treatments with therapies like intravesical therapy with BCG. And I will remind everybody that the BCAN website has a number of really great resources. And in your handout section on the webinar today is a direct page that has all of the links to all of those resources, including our Bladder Cancer Get the Facts page and other webinars, including one that Dr. Hoffman-Censits did for us not too long ago as well. So all of those things are going to be really great resources, and many of them have great questions that other patients wish they had asked their doctors before going through treatments and things like that. So I think that's really a benefit. So please take a look at that, because we won't be able to get to all of those. Dr. Hoffman-Censits, we have another question from somebody who was newly diagnosed with a T2 stage bladder cancer. Is there any data about disease-free survival or overall survival with a maximal TERP alone or without any kind of chemoradiation combination? Do you know anything, that you can predict from that statement at all?
Yeah, I think what I would say is that to think about a small muscle-invasive tumor, and then hearing the treatment that we discuss with patients to treat that tumor, I'm sure it seems overwhelming to hear about chemotherapy followed by a life-changing surgery, or chemotherapy and radiation together. But the reason that we do that is because the survival with just doing a TUR alone is, I think, woefully inadequate. And so TUR alone is not at all considered standard of care. And I think that would be a discussion to have with a urologist. And I think, the other thing that sometimes I find is very helpful, Stephanie, I know that this is something that you and we can advocate for as well, is, even though bladder cancer is a common disease, muscle invasive and locally advanced bladder cancer, as you can see, is not. And so hearing maybe about how different physicians or different centers may think about your disease is important. And I think if if someone is interested in hearing more about that, that may be a great opportunity for a second or another opinion to talk to a multidisciplinary team about that.
Mm-hmm. Absolutely. And again, you're never going to have a problem by asking too many questions. And that's how you do learn about your disease and how you begin to find out more of the details. And it never hurts to get a second opinion as well. And I know a number of people had asked specifically questions related to radiation therapy. And those are all good questions to bring up with the radiation oncologist, more so than you would be able to answer them directly, because that's not your area of expertise per se, right?
Right. And I know that someone had asked a question about things like, things like positioning and brachytherapy. And I think that if you were to read the literature, Stephanie, that you would find, small trials that are talking about different modalities of radiation and different schedules of radiation, as well as someone also asked about different chemotherapy regimens. When we choose the chemotherapy, it's oftentimes based on comorbidities. So if someone is a candidate to get, large doses or systemic chemotherapy, we sometimes will talk about that, followed by chemoradiation. Or if someone's maybe a little bit on the more frail side with problems with their kidneys, then we're going to choose a regimen that is not going to have as high of a risk to have toxicity to the kidney. So in terms of one chemotherapy versus the other, again, as far as I know, we really don't have that information, but chemotherapy regimens with radiation have been tested really just in different patient populations so that we have the different options, but not necessarily one better than the other.
Great. Thank you so much. I think we have time for probably one more question, and this one I'm going to ask because it's kind of a rare form of bladder cancer. It's specifically addressing standard of care in small cell metastatic that's spread to the lymph node and bone. Is that considered a distant metastasis? Can you talk anything about the standard of care specific to small cell bladder cancer?
Yeah, well, Stephanie, as you know, this is a particular area of interest for me because small cell bladder cancer is so rare that most of us are not really seeing that much of it. How we treat small cell bladder cancer is similar to how we treat traditional bladder cancer. It's typically a platinum-based regimen, but in general, instead of using cisplatin and gemcitabine or MVAC, we tend to use cis or carboplatin combined with another drug called etoposide, and that mimics what we do in small cell lung cancer, which is a much more common disease. But it happens so infrequently that to get large populations of patients together to then populate a clinical trial is challenging. And then the other issue is that because the biology of the tumor is different and the behavior is different, that small cell bladder cancers tend to be more aggressive. Unfortunately, sponsors, including, large other pharmaceutical companies or others, have decided to exclude those patients from clinical trials. So we don't have a lot of information of how those tumors behave on therapy like immunotherapy. And this is a major unmet need in our field, and one that I and others are trying to address in different ways. If a tumor moves from the bladder into any other part of the body, into bone, lung, lymph nodes, then that is a metastatic tumor, and that tumor is then felt to be potentially treatable, but unlikely curable. I think the other important thing, and we talked a little bit about that next generation sequencing, that's another tool that we have that is really commercially available. I know that there's a lot of cancer centers that will advertise it. Some cancer centers will just do that testing on the tumor to get more information about it, and especially with rare tumors like small cell bladder cancer, I think having that additional information and then looking at that database that the tumor provides to us and then thinking about what clinical trial options a patient might have is, for small cell and for traditional bladder cancer is important.
Okay. Well, thank you. Again, these are really challenging questions to really give a precise answer to because you don't have all of the details. And as you pointed out, this is an extremely rare form of bladder cancer, so we don't even have a lot of studies that are specifically targeting this. So I think this is about all we have time for questions today. Judy, would you like to finish up anything else? I'd like to thank Dr. Hoffman-Censits for a wonderful program.
Yes.
Oh, thank you for inviting me, Stephanie, and thank you to the Inspire Network.
Thank you so much, Dr. Hoffman-Censits and Stephanie, for this great information. We're so glad that you were able to join us today. And unfortunately, we weren't able to get to every single question. We do encourage you to visit our BCAN Inspire community, to talk to other members about your experiences by going to beacon.inspire.com. And as we said earlier, we will be sending out a link to this presentation to everyone on Friday. And we'd love to hear from you, so you can reach us at partner@inspire.com with any questions or comments. And thank you again for your participation, and have a great rest of the day.